I am Baek Kim at Seoul National University Bundang Hospital Plastic Surgery. It's my great honor to be here to present our strategy to handle cleft nasal deformity in cleft rhinoplasty. As you know, lip is the base of nose, so the repair of cleft lip always continues with the nasal reconstruction, even when first canaloplasty is performed. But for deciding the proper moment for cleft rhinoplasty, there are various aspects to consider. First, if adversely affecting integrity or growth of normal structure. Second is the patient and family's concern is how much, and then social class pressure, how affect the patient mind. Especially for the primary rhinoplasty, any possible negative effect on growth has been the main concern. Nowadays, early surgery has been regarded as minimal adverse effect in many literature, and many rhinoplasty show the beneficial evidence related to decreased revision rates. Previously, many experts have reported the primary rhinoplasty method as thorough lateral cartilage release and suture anchoring steps. According to each surgeon's philosophy, dissection range and fixation way showed several variations. This PRS article showed some examples about the extensive approach and suture anchoring method. As I mentioned first, the upper part of lip as the base of nose is the fundamental area to be managed for the satisfactory nasal shape. Complete release of abnormal insertion of orbicularis oris muscle from the cleft margins, ipsilateral ala base, and the contralateral nostril base is the first step. Then, oris muscle repair as long as normal side piltoral height is the next step. The height level of muscle string reconstruction directly decide the nostril seal shape. This is the live video showing the oris muscle repair. Almost cleft surgeons know the vermilion marginal muscle repair prevent notching or fusiform deformity. As like that, final reconstruction of muscle string at the superior border result volumetric seal with long-term maintenance of approximated nostril width. To cover the full height muscle column, well-designed medial C-flap, lateral L-flap, and posterior M-flap must be composed sufficiently. After finishing muscle walk with M-flap, L-flap, C-flap, nostril seal outer layer is covered as symmetric shape as contralateral side. This is the video about the nostril seal lining repair. In our technique, L-flap cover posterior side of oris muscle, and both M-flap and C-flap make a speromedial lining of nostril seal. This step is very essential to shape the natural contour from columella to nostril seal base. After the nasal base was repaired enough, then nostril loop symmetry is the next target. In the narrow scope, this nostril loop management is considered as cleft rhinoplasty. Because buckling or overhanging at subtriangle is mainly formed with soft tissue excess, we prefer reverse view incision approach to reset nostril superior margin. This is the real video of primary rhinoplasty performed to microform cleft patient. After design along the symmetric line to contralateral nostril, Additional tattooing could be done to maintain the line during local injection. After local injection, preparation, and with 15 blade, subcutaneous depth incision is done. And then sharp seizure dissection is proceeded along the supracartilaginous plane on the low lateral cartilage and the lateral crus. To prevent hematoma, bipolar hemostasis and additional dissection is performed in upper lateral cartilage lower border. After checking the full release and freely movable reversible flap, two needles of Dobram 7 nylon pass through from opposite septum and upper lateral cartilage junction point. One of the two needles anchored at the lateral crus of lower lateral cartilage, and then the two threads tied securely for repositioning reversible flap. Next, the new nostril upper margin was closed with 7 black silk. Finally, suitable laser retainer was applied. This is the patient pre and post photo. Above low is the complete complete cleft patient. Low is the same patient post photo. You can check the well-maintained nostril width and then nostril height. These two patients is incomplete case. Upper low is preoperative, low is the same patient's postoperative view. You can check the well-maintained nostril shape with the primary rhinoplasty. Now we will move on the correction of secondary deformity of cleft nose. In evaluating every case, we are focusing into 3 points. First, skeletal deficiency. It means depressed nostril base. Second, cartilage framework weakness. It means alar flaring and buckling. Final, soft tissue redundancy. It means wide alar base and soft triangle drooping. There is no doubt that the skeletal base should be managed first as the foremost important part. All cleft lip nose has various degree of skeletal deficiency. Over the firm ground, any further constructions could be intended, so 3D evaluation like CT scan is a mandatory step before surgery. We have published some articles pointing out the importance of skeletal base in cleft rhinoplasty. This first case shows the lower level of cleft side nostril base. He got closed rhinoplasty, including formal bone graft on depressed piriform aperture. This is intraoperative view showing bone graft to augment the depressed nostril base. Immediate post-op view looks well-corrected nostril base level. Post-op 7 months, his nostril base and loop symmetric level was maintained well. Pre and post-operative worm's eye view, you can check the result of the correction correction with the bone graft at nostril base and the reverse U incision on the nostril loop. This second case also shows the lower level of cleft side nostril base. He also has definite deviation of cartilaginous septum. His upper alveolus and lower filiform aperture of cleft side showed concave depression. So we did more bone graft there during open rhinoplasty and nasal osteotomy and T-plasty. Immediate post-op view features well-corrected nostril base and straightened nasal dorsum. Post-op 6 months, his nostril base, symmetric level, and straight dorsum was maintained well. In the pre- and post-operative worm's eye view, you can check the result of operation. His nostril base elevated and his nostril loop maintained during 6 months. The next essential part in cleft rhinoplasty is reinforce the cleft side ala cartilage. Because all cleft lip nasal ala has various degree of atrophic form of low lateral cartilage, and nostril height and shape depends on the firmness of ala cartilage. We introduced crural reinforcement technique in this article. The concept of surgery is like this illustration. This third case shows the ala flaring and buckling of cleft side nostril. During rhinoplasty, we got lateral crural turnover flap. In this middle post-op view, we can check the nasal flaring correction by the reinforcing lateral crus of cleft side. In post-op 2-year views, nostril symmetry maintains well. You can compare the pre-operative and post-operative worm's eye view photos. This fourth case shows wide ala with depressed and flat nostril loop. In his rhinoplasty record, he got lateral crural strut graft to reinforcing cleft side nostril with bilateral ala base resection. This is immediate post-op view. In this post-op 1 year 10 months views, his changed nostril shape was kept well, and you can check the change between preoperative and postoperative worm's eye view photos. This fifth case shows the similar feature to the third case that have ala flaring and buckling of cleft side nostril. During rhinoplasty, he got lateral crural turnover flap with lateral strut graft to reinforce nasal side wall. In immediate post-op photo, his cleft side ala shape changed symmetry to normal side. In post-op 1 year views, both symmetry nostril shape maintains well. Pre and post worm's eye view, you can check the change of this surgery. The final key point in cleft rhinoplasty is tucking the soft tissue excess. In spite of primary repair to cleft, as growing excessive nostril width with hanging soft triangle is inevitable due to perialar levator muscles and combined skeletal deformity. This sixth case is the typical example of the stretched soft tissue around the cleft side nostril. During his rhinoplasty, he got orbicularis oris muscle repair at nostril seal again and additional ala chinching suture. This immediate post-op view shows his corrected nostril width. In this 2-year post-op view, his reapproximated nostril seal width was sustained well. You can check the change between pre and post-operative nostril shape. This last case shows typical feature of bilateral cleft nose. Beside the bifidal cartilage repair, we did reapproximation of orbicularis oris muscle through nostril seal to vermilion. This is immediate post-op view showing much narrower ala base than preoperative. In post-op 1 year and 3 months, she is very satisfied with more natural and balanced nasal tip and base shape. You can check the preoperative and post-operative on-site view and the change of nostril shape after surgery. This is the last slide and take-home message. In cleft rhinoplasty, we should be aware of the importance of skeletal base and concentrate or reinforce framework with tucking with remnant envelope. Thank you for your attention to this presentation.